The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk. Okay, welcome everyone to another episode of the Success in Practice podcast. Today I'm joined by Louise Bibby. Louise has 15 years experience in osteopathy, strength and conditioning, coaching, sports medicine support, business, leadership and mentoring. She has a passion for sport and performance, injury management and consulting. More recently, she has advanced through her career. She has learnt more about what motivates her as an individual. She is driven each day by the success she has achieved, becoming a trusted and recognised professional leader, educator and mentor within the osteopathic profession, workplaces, sporting teams and affiliated organisations. Her experience has been gained through running her own osteopathic practice, founding a national sports network that aims to enhance the representation of osteopaths in Australian sport, and I think that's called the Osteopathy Sports Network. That's right. So Louise is also the director of Central Mallee Health, Central Mallee Fitness, Outreach Osteo, and Osteo Sports Network. Louise was Australia's first, I think, titled Advanced Sports Osteopath in 2020, that was, Louise, and the Australian Osteopath of the Year in 2024 at the Australian Allied Health Awards, as well as receiving acknowledgement for Allied Health Rural and Remote Excellence in the preceding years. Louise, welcome to the podcast. Thanks for joining me today.
Thanks for having me, Sammy. It's great to be here and nearly at my bedtime, but well done on being here and inviting me on the podcast.
Yeah, well, I'm sure we'll give the listeners a bit of gold there. And look, one of the things that I normally do when I get ready for this podcast is I look at people's bios on their websites, especially practitioners that have a lot of. And I went to your website at Central Mallee, and I read it, and I was like, well, what do I do with this? I was like,
so that's the fun one. That's just the Central Mallee Health one.
And I was like, hold on, do I get some gin? Do I ask her to put some gin and tonic on while she's while she's doing the podcast? Do we talk about? I think it was the horse riding. Do we talk about?
Yep.
Yeah. So it's that was a quirky one. That really, but it was a good one because it put me off a little. I'm like, oh my god, I've got to work something out here. I'm like, it's Monday. We record on a Tuesday normally, and it's Monday afternoon. Like, I got this in the bag.
Well,
I'll go to a website and it's all sorted.
To be fair, if I led with that bio on my clinic website, people would just be like, oh, like everyone's already gone. They're not even listening to this podcast. They tuned out, the first 5 seconds.
Oh, no. I'm sure we'll give them much more to listen to. So I guess let's get into it. Let's get started. And the way I usually start is I ask about you and your backstory. People want to know about you and growing up as a young girl, a young woman, and also what was your education like and what got you into osteopathy.
Yeah, there's obviously a lot to my story, so I'll try to make each part of my story pretty quick. But just in general, I was born in the Mallee in a place called Berrywillick, which is about halfway between Bendigo and Mildura. Just went to a local Catholic school up to Tyrrell College, and I went to boarding school in year 11. I think I was 15 when I left home to Caulfield Grammar in East St Kilda, which, absolutely sort of started fostering my passion for leadership, being on the school committee and house captain and having those roles and responsibilities early on. So I was a pretty dedicated student. I had a bit of homesickness and all of those sorts of things, but, being a young kid, following my siblings away to boarding school, it just, presented a whole world of opportunities that weren't on offer for me in the rural sort of schools that we had, although I did have the best upbringing, in those tiny schools, having small classes and lots of attention to detail and one-on-one time. It just, I didn't have the ability to study things like chemistry in year 12, so I had to move away. So yeah, I've always been a Mallee girl, and I started in year 11. I think my interest in osteopathy didn't come until really late. Even in the Mallee, I had never even seen a physical therapist, no physio, no chiro, no podiatry. I think I'd been to the dentist and the GP, and that was my experience with allied health and medicine. So by the time I got to year 11, I sat with the careers officer, and she's like, "Oh, what would you like to do?" And I said, "Oh, perhaps physio." But at the time, everyone in my year, all the sporty girls, I was doing lots of APS sport and all those things, and they all wanted to be physios. And I thought, I just wanted to be a little bit different. I've always been a little bit different, not wanted to follow the crowd too much, maybe lead my own with my own bull bar. So I think someone mentioned that we had a Mallee boy by the name of Greg Conlon, who was a chiropractor in Northcote on Queen's Road there. And he was a Mallee boy, and someone said, "Why don't you go and see Greg?" So I went and had my first chiropractic adjustment in year 11. And I was talking to him about it. I thought it was amazing. And I was playing netball at the time, first netball, and I had some ankle issues. I'd rolled my ankle, and my experience as well. Then I went to a physiotherapist and had the ultrasound and some taping just to go to training. And I didn't really understand why, as a 15, 16-year-old girl, I'm getting in a taxi to go to Rip and Lee Physio, just to tape my ankles to go back to training. So when I spoke to Greg, I said, "I'm having this issue." And he said, "Oh, well, my big bald-headed brother's an osteopath. You might know him. His name's Josh Conlon. He works in Moonee Ponds with Glenn Bales." And obviously, the osteopathic world knows Glenn for his being a master of manipulation. And he said, "You should go see my brother as well. Make sure you do that for your work experience." So I think I might have been there in year 12, I think. And Josh was, when I walked in, he's originally, again, from Nandaly, from the Mallee. And I walk in, I see this Mallee boy, similar to some of the country fellas that we affectionately know from home. And he's 120 kilos. He's 6 foot. He's, a big guy. And I remember him just big guy. But in a good way, big heart, very funny, very caring, welcomed me into the clinic. And he basically got my foot and wrang it out like a tea towel. I've never in my life experienced being cracked from head to toe, but in a way that then also fostered "What are you doing? Netball. What are you doing? Do these exercises." And he rubbed my muscles and he did everything. And I went back to school just thinking, why would I shoot for the moon when I can shoot for the stars? I remember thinking, explaining it to people. Why do you want to be an osteopath? I didn't really know exactly what the principles were, what it was, but I'd seen him and I was pretty, impulsive. So I put that as my number one at VU. So I think I even turned up to my VU day one still not knowing what osteopathy was, but a good friend in Ben McDonald, who was from Caulfield at the same time, he was applying as well, and he ended up being an anaesthetist. But, he started in osteopathy with me, and it was just that nice little journey into our first year of osteopathy. So, that was my journey to Victoria University.
What year was that? What year was that, Louise?
That was, it was in 2005. So...
So what year was that you started at VU?
So the year was 2005. Okay. So Victoria University. And there was a unique thing happening at the time. I'm not sure some people will obviously remember that was the year that they had begun the transition to the St Albans campus in Melbourne. So the rest of the cohort were at City Flinders. Beautiful campus, nice clinic, an amazing spot to be. And we were able to go there for some of our lectures, but for the majority of the week, my introduction to osteopathy was out at the St Albans clinic. So we were the only cohort moved out. The staff were all travelling as well. They'd established the student clinic there with some massage, I think, and myotherapy and paramedics as well. So we were sort of sharing that space and obviously the science labs and those sorts of things. So the introduction to osteopathy at St Albans with the practical room. There's 50 of us, bright-eyed, bushy-tailed, stuffed in this practical room. And then, these 3-hour lunch breaks where all of us, like the Goonies, would just migrate to the canteen and hang out for 2-3 hours. I was laughing with some friends on the weekend about how the order of the day was always the gigantic chicken schnitzels. And we'd always eat these massive schnitzels and go back into class and not be able to tolerate whatever was happening, or would sit in
No.
a 3 hour biochemistry lecture with Vishnu. Do you recognize the structure? We were, struggling with the language barrier and falling asleep, and
Yeah.
and it was a real challenge going between the two campuses. But we worked really hard as a student cohort with the staff, and we put up some really good reasons and a really great petition to the university as why we should be moved back into the city with our counterparts. So, at the end of that year, we were moved back into City Flinders campus, just from an operation point of view for staff, for students to be together with the concept that, get St Albans osteopathic, school ready, and we'll all move out together. So, I suppose plans changed and they've developed the university a different way with the new Queen Street campus and those sorts of things. So, yeah, they've been super lucky. I was listening to some of your other episodes, and it was funny. I literally caught up with Matt Cooper and Bill Adamson and Ed Wittich on the weekend. We just like to catch up every few years. And, obviously Matt's the president of Osteopathy Australia. And I said, let's just do this thing that everyone else has done and just talk about, those people that were at the university when we arrived. So it's a nice generational thing to do, I think, with this podcast. So, in our first year, we had the likes of Gary Fryer, Jim Kiados and Brett Vaughan, Rick Steer for our anatomy, Lainey Cameron, Vishnu, Pat McLaughlin and Kylie Fitzgerald was doing a lot with the leadership there. We had Jim in the anatomy lab and, Radio Martin. And then a lot of those other ones you have talked about before in the Cam Goslings, the Phil Tians, Matt Home, Marnie Norfolk, Denise Cornell. We had Paul Francis for biomechanics, who's now working overseas. We had Della for our neuro, Jade Scott in business, Brian Nichols, Jenny Hines at physio for rehab. We had some great, some amazing lectures. And I apologise if we've missed anybody, but we did this over a few drinks. So, and in my personal, my clinicians in Jade Scott, Carl Ridgway, Chris McFarlane, John Pitcher. So those are some of those familiar faces that I remember from my time at university. So
Yeah, I've had discussions with a lot of those people that you've just mentioned, and look, being somebody I'm in the Sydney world of osteopathy, it's one of the great things about doing this is that I get to meet the people that have kind of mentored, yourself and a few other people as well, and it's been good because it lines up with the similar process that we went through, and you can kind of relate. It doesn't matter. You kind of relate. Students, especially osteopathic students, I think when you look back at your student life, even if you've studied at RMIT or VU or UWS or SCU or wherever you did you kind of can relate to the mindset where it was like so hard and so tough, and then on the other side, it was like just a pleasure to be there.
And mind you, I apologise to all of those lecturers and mentors. I wasn't the most diligent of students. I was very much involved in the social aspect of university. So with the student union moving into the SOMA group, the balls, the camps, running the membership. I think probably one of my favourite things, and it established early on that collecting and connecting of people has always been something that I love. So I think I've come out of university, my biggest thing, I wasn't an academic. I sat a supplementary exam for research. Apologies to all of those in our master's program as well. We did the efficacy of osteopathic treatment for patients with fibromyalgia. And I wasn't an academic in terms of writing that up, but I helped with the data.
It's okay. It's not.
Thanks.
Yeah, well, academia is not for everybody. I think there's a space there also for someone who's a networker.
Yeah, I was the most epic hype girl you could have through university. Yeah. So I think we carried through the reunions, the balls, the barbecue, the end of year functions. That was me. So I think when I got to the end of university, I was never an original thinker of Sutherland. I like to say, I used to have this saying, I'm a footstool for Sutherland, happy for all the academics to put their feet on me and I'll carry the team. And then, I think coming out of university, though, the transition was a little bit difficult because I suppose it was that collaboration of, I had left home at a really early age. I'd spent 5 years really busy in the city, and The other part of it was my grandparents had both passed away and had been in palliative care through fourth year and fifth year. So I actually hadn't had a great chance as an adult to reconnect with my hometown or my family, or, as an adult, just, I thought, you were never going to live at home again. So,
Mm.
I came out of university and I went straight home to the Mallee. And I think for probably about 4 to 5 months, I worked on the local grain depot, as I had all summer.
Mm.
While all of my friends had done their internships in fifth year, I didn't do any internships. I think I got Josh Conlon to sign me off for every 50 hours, whether I did them or not. Had a good ally there. But I did connect with a lot of professionals. And I was early out. I went to all the conferences and things like that. But, I didn't probably do osteopathy and get really into it until about the April of my first year out, 2010. I graduated in 2009. And it was when I had fostered those relationships by working at home as an adult that the people at home actually saw me for the value that I could bring. And it was actually sitting in the pub with the Berry Woolwich pub was famous for having one of the coldest beers in Australia, an icy glass, sitting with the farmers along the bench and having their families in the next room, and actually just starting to talk to all of these people that I grew up around and actually hearing their sad stories or their difficulties or their troubles. And I remember just grabbing the table at the end of one of those harvest times, about this time, and I started treating people at their homes. So I went around. I remember the same first 8 people that I saw. It was couples, 4 houses. And I had this amount of cash in my hand at the end of the day that I looked at and I thought, these people have trusted me with this. They have nothing here. I could actually do this. So I made these steps to call the Bullock Shire. They gave me the Maternal Child Health Centre, free of charge for 2 years if I brought it up to a working standard. And I started my Central Mallee Health in Berry Woolwich, the population of 60 people, 60 to 100, in the main town, halfway between Bendigo and Mildura, 2 hours from everywhere, an hour to the closest physio, a few local GPs that had been there for 25 years, and no private allied health clinic in any capacity. And I didn't know anything, but it was a great little dive. I didn't care if I was called the massage therapist or people didn't know who I was. I'd treat them for an hour and a half and rub their toes and do anything I could to just make people feel like I was there for them. But that's when the panic stations hit, because I didn't know how to run a business. And I had this night where I went to pick up the phone and my phone rang, and that was Jade Scott. And she urgently needed a maternity position filled. She knew I didn't have a job, and I also was panicking. So we came to this mutual agreement that if I filled the maternity contract for her, she would teach me everything I needed to know about business. So that began my first introduction to having a lifelong mentor, one that you're fiercely loyal to and you fiercely support, but you get their love and support in return. And from there, I was able to foster my business from, after my first year in practice, driving between Melton, Bacchus Marsh and Berry Woolwich every week. That's where the success started. So that's
Yeah.
the introduction to my clinic.
Well, let me, I guess there's a few questions there, and I want to kind of delve into that a little bit. First of all, I'm sure that you propped up the St. Albans economy with all those schnitzels that you bought, and they would have sorely missed
Absolutely.
those. So, and I think secondly, I don't think that an apology is needed if you're not an academic. I think you're somebody who might bring something else to the table, and I think also having students, it's very hard for students to run research and do, I think practitioners, once they develop some experience, a lot of them are going back to research because they've got something they're passionate about. So,
I think it was
um,
just more the ADHD, the hyperactivity thing. I couldn't just concentrate on those
well, but that's
really.
okay. It's not for everybody. And I guess like it'll give you skill sets in other areas that I'm
I
sure you've
just
used.
I just like to think that I was at least a little bit funny and, of course, memorable to them all.
Yeah, I'm sure you were. Um, Now, I want to ask you, when did you said that you didn't really kind of apply osteopathy initially because you hadn't done the internship but when did that kind of click for you? Was that as a
Uh,
student or was it as a young practitioner?
no,
When did
I was
osteopathy kind of start to click for you?
I think there's always that question of how did you go in the Mallee, starting a country rural practice, no mentorship, how did that work for you? And I'm not being that I didn't do osteopathy. It's just it meant that I had a slower approach to the way I did things. I didn't have a mentor in the clinic with me. I didn't really have anyone to ask questions apart from when I was at Bacchus Marsh and I could ask those limited questions. But you know that you're only just beginning in those first 3 years. So even after my contract at Western Region Health, for those first 2 years, expanding to Woomalang and Birchip and working with the GPs and starting these rural networks, I was still very much by myself learning from my own outcomes. And that's not a bad thing. These days there's all these types of protocols and fast tracks and inductions into clinics and all of those things. But I think the best thing about doing it the slow way without the silver spoon, so to say, is that I actually had to really, really think about what I was doing, what my impact and my outcomes were by putting my hands on. And they weren't always the greatest, but I got the opportunity to learn that. So you can see a hamstring or so 1,000 different ways, and you might not always get it right. But it's actually through your own assessment. And again, remembering that in the rural clinics, you are the first line of defence. So from second year, very early on, you're the first line of defence for ruptures, for traumas, for concussions, for everything. I can speak to people these days that have been professionals for 20 years and they've only ever felt 2 or 3 ruptured ACLs. But I've had, 100 ACLs that I've felt more, ruptured ACLs, all sorts of things, torn biceps. You end up becoming this trauma triage place as well. So you always get a client. They never have an image. They never have any scans or any information that they bring. They haven't seen the GP. They haven't seen a specialist, and they're speaking to you for the first time. So, sometimes in the city, you might find that someone will present to a strength and conditioning coach or an osteopath or a physio, and they've got this beautiful scan that just gives them the information, or they've been sent from the sports doctor saying, hey, do this for me. So, the Malley's a really long place from the city. It can be a 6-week wait sometimes to see a GP. It can be 6 weeks wait for a simple ultrasound and a couple of weeks for x-ray. And if you do need an MRI, you've got to try to see if you can get your diagnosis to a point where you really need to send them, because people can't just go to the MRI machine in their lunch break. They can't go to the sports doctor in their lunch break. They have to get their kids looked after, take a day of annual leave. They have to travel to the city, get accommodation, try to do the MRI one day, see the surgeon the next. There's a lot of facilitation there for families and a lot of other difficulties. So for me, I had to sort of work out a way of, can I come to a osteopathic diagnosis, but how the hell am I going to learn all of this other stuff? So everyone always says the segue into how did you become a sports osteopath? I'm not a sports osteopath because I worked in elite sport, a sports trainer into the head of physio into the AFL team. I'm a sports osteopath because I spent the first 6 to 7 years of my life in the surgeon and sports doctor's office with my clients, because I would travel down. I had to, in a very, very quick way, learn everything that I could possibly know about orthopedics, about imaging and neurology. And I had to go to those surgeons and those physios and how do you really assess this orthopedic, how do I get these results? So I would say that one of the things that people don't know about me is that I've probably attended upwards of 600 appointments with clients at the surgeons and sports doctors, pre-op, post-op. I've sat there. I've done my little, I snuck into Lynn Watson and Simon Bolster's level 1 shoulder course when it was only for physios. And then 5 years later, when I came out as an osteopath, I went and said, can I come and sit in the Melbourne shoulder group every other Monday with my clients? I'm going to send them down. Can I come in? The hip and groin pain clinic, Melbourne Orthopaedic Group, going with finding out what do they do that I can do before I have to send them. So my passion for that is sort of where it sparked that interest in, one, osteopathy. I always used it. Traditionally, I did a lot of early osteopathic CPD, but it was sort of around that 5 to 6 year mark in practice where I started really angling towards sport. I did had my own ACL injury, had to turn to swimming and golf. I studied my ASCA level 1 and started really fostering my networks with strength and conditioning, sports, surgeons, orthopedics. I did internships at strength and conditioning gyms, some of the big places, and, really started to foster, that's when even I turned my interest from, the traditional osteopathic CPD, the art of osteopathy, into the more sports-based Sports Medicine Australia conferences, the ASCA conferences, hanging out with different people. So that sort of then fostered this beautiful thing with me, that I had the art of osteopathy, the beautiful ability to treat my clients like an osteopath, but to assess them, diagnose them, and rehabilitate them similar to sports, strength and conditioning coach, or how the surgeons would recommend. So my surgical referral, my sports doctor referral now is a list of 20 to 30 surgeons and sports doctors on my phone. And it's a quick SMS, and it happens the other way as well. Hey, here's an Achilles rupture. They're at this stage. I know you'll be able to handle them. So that's been the beauty of working in rural practice. I'm a sports osteopath because I saw everything. I was exposed to so much, and it was panic stations in learning how to deal with it. So I had to foster amazing sports medicine relationships to be able to leverage my success with clients in the Valley.
So I guess you've answered how you kind of practice this hybrid of osteopathy and then obviously orthopedic assessment and understanding how to progress tissues from, I guess, from injury to then back to rehabilitate those tissues to use and function and back to sport and so forth. In terms of osteopathy, though, in terms of the actual, I guess what you call the art of osteopathy, the principles that we use. When did that click for you? Like, were there certain? I mean, you talked about a lot of people that mentored you through university. When did that kind of start to go, look, if I apply the principles in this fashion here, I can get a really good result? And you mentioned a lot of the farmers that used to treat, and I think that's fantastic. They're not athletes, but they're bloody hard workers.
Absolutely.
And they've got a whole bunch of injuries that they never complain about.
Yeah.
And did you get to a point where you go, look, if I can move their thoracics and really get their lumbars moving, I can make a change to their life? Like, when did it click for you, the osteopathy and how that affects people's lives? At what point did you go, aha, I've got something really special here?
Hello, everyone. I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow, and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you, and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode. And please, don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
Yeah, like I did all of the traditional osteopathy. Like I've done some BLT courses. I remember going to do functional counter strain, going to some of the mixed HVLA, there's lots of little mixed seminars and things for osteopathy. You do the dry needling, you do all of those sorts of things. And I remember always treating, because I spent a lot of time with people. So it's sort of working out, that interregional approach to treating one thing that affects the other. So I always did that, and I learned that from contracting as well at the other business that I was at. So I think it was more so for
Who
me.
affected you? Who affected you in that? Who really influenced you in that sense? Did you
I
have
think
kind of some mentors or early influences or?
well, one of my tricks was that I used to just go and get treated by them. Because I was the only osteopath. The hardest thing for me a lot of my career was that I just was alone for so many years until 2014 when I expanded the business to Swan Hill, which I promised myself, the 5 years before that I would never do it. I want to travel. I want to be like, I don't want to be tied down to a clinic. But I was so incredibly alone in what I was doing. And apart from Jade, who was a very strong mentor of mine, I started doing things that, was a little bit out of the box. So I remember going to my first osteopathy conference. So I went to a few of those in my first few years out. And I'm a magnet for people. I love connecting with people. So I'd have great conversations and invite myself to their clinics and all of those sorts of things. And I remember after a conference at the Gold Coast, there was a few of us fifth years that had stuck around that last night, and we mingled, ended up having this beautiful dinner with a lot of the Osteopathy Australia board. The rugby was on, Australia, New Zealand, and we went up to the top of this Q1 tower and we had a beautiful dinner, and it was just, I remember the time there was like, Rowan Armstrong and Shane Heslops, and, there was Claire, she's at Life Force, and I was running the Osteopathy Australia drinks with them. There was just these incredible people. And I went to these end of year Christmas drinks. I can't remember. Sorry, Claire. I can't remember your last name, but I'll remember it in a minute. and we were organising the Christmas drinks. They were on South Bank, and there was about 20 people that came. We had, the likes of Bruce Duncan there. We had Damien Generini, Gunga. We had these amazing people, and I remember meeting them in my second year out, just going, these are the next generation. And I was absolutely vibing them, loving them. And I've spent, the next however many years after that continuing to connect with them, going to their clinics to have a treatment. He's 20 years out. What does he do with his hands? And how does that work on me? And then trying to foster that. So I didn't probably learn how osteopathy clicked because I learned it in courses. I did it by getting treated by those that I thought to be the giants in our industry. For me, it was always about continual learning. How do I learn off the best sports doctors, surgeons and whatever? But how do I be the best osteopath I can be? How do I pull what they know and how they treat? So I'm a mixed bag. My life's been this cross-fertilization of all sorts of things. But I love my ability to approach something quietly as an osteopath. But it's all depending on the patient. If they've got a performance goal and want a performance type treatment, I can then leverage towards my sports osteopathy. So the ability to be quiet, check the fascia, do some cranial, do those sorts of things. I treat pediatrics, geriatrics. Like I can do, I've sat with hand therapists at Action Rehab and learned about splinting and, all of these things. You can apply the best of what you know in the way that you need to apply it. So in regards to, people always say, well, what is sports osteopathy then versus what is osteopathy? So, and it can be tricky. Again, I explain it differently depending on the platform or the audience that I'm speaking to. Because if I'm
speak to other osteopaths and explain to them.
Yeah, so like if I'm speaking to other osteopaths and I want to talk like an osteopath to osteopaths, or I'm teaching, when I was at the Australian College of Sports and Exercise Physicians doing their tutes for those few years, explaining to them what osteopathy was, like other modalities of the bodies, other modalities that treat the body. It's just another way of looking at the body, based on the fact that the body's that integrated unit, where our physical and our actions and habits, behavior, and the environment that's around us all has this influence on our body. So the thing about our body is it has this amazing and great ability to adapt to stress and load. It can alter the structure and therefore the function of the way we work. So at the core, though, the body just always wants to be in balance. It strives to heal. Sometimes it can't, but sometimes it wants to. So an osteopath will, examine the body and the structure of it and how it's required to function, and just identify whether either of those two things needs to be changed to help restore what that person needs, that balance or that health.
Right.
Sometimes we need to change the structure, sometimes we don't. So to do that, osteopaths, we have our own techniques, our own hands-on approach that's very, very specific, different to other modalities, but we take that wide lens view of the body to understand how one region will affect another, while also focusing on that capacity building and that behavioural change.
And so if you're talking to other osteopaths and they ask you, what's the difference between osteopathy and then sports osteopathy?
Yeah.
Is it just osteopathy applied to athletes, or
No,
is it
not at all.
So yeah, explain that. So what's the difference between an osteopath and then a sports osteopath?
Well, the way in which the sports title is seen is sports management. So for me, just treating a sports injury is being an osteopath. Yeah, we're treating the body. Treating an injury is treating an athlete. You're an osteopath and you're treating an injury. The difference in a sports osteopathy is you have to understand the context of everything that is required. So what is the requirement of that athlete? What is the requirement of the sport? What are the environments they work in? Is the environment, is the sport, or is something, the way the athlete is built or the way they're training, impacting this injury? That's the difference. So then, therefore, once you understand the athlete, understand the sport, understand the sporting environment, it's then what happens once you fix the injury. So just because they're feeling better doesn't mean that they're back to a performance capacity. So for me, it's about improving the injury, letting the body heal, letting the body find its, where it feels the best and when it's back at its balance. But we always understand that tissue has a tolerance or a capacity. And if there was an injury, usually my theory is that whatever the load or the stress that was being placed on that athlete, the hamstring, the knee, the whatever, if you don't address those stress factors or that load management, they're going to suffer that injury again. So it becomes this process of, one, we're back, we're feeling better, but we always know that we lose a little bit of integrity in ligaments, or we lose a bit of strength. So just when we start to feel better, we need to have a readaptation phase back to where we were from even a strength point of view. Yeah. So there's this phase of regeneration or strength programming to build tissue tolerance, to build capacity. That mountain climber, he got really sick for a month and he tumbled down that mountain. Now he's got to put a backpack on. We're going to have to build him back up slowly. There's an analogy. So the idea is that once we've built back some capacity and some strength training, it's then how do we return them? And again, the way we return, whether it's an individual team sport person, field sports versus individual sports, how do we return someone to training? Then how do we return them? So we might return them to restricted training with certain parameters. Then we might, unrestrict them. So we might say, look, you can contact now, but you're not allowed to sprint. Because we're still building up the strength of the hamstring, and then we're going to add some speed and strength, or the last phase on return to play at the end. So it's actually understanding the return to training, return to play, return to performance, and then even once they're back, I follow all my athletes through a competitive season, touching base with wellness. So sending them out those screens. How are you feeling? Are we modified training this week, or are we full training? Are we on top of, have you noticed anything? So it's a lot of player monitoring, a lot of player wellness, a lot of going to sports fields and actually doing it with them outside of the treatment room or in the gym. So I spend it depends. Some weeks I can be a real traditional osteopath and not step in the gym once because I'm treating lots of babies. But then the next week I might be doing a whole heap of glad rehab, like knee and hip osteoarthritis, ACL management, doing youth athlete development, or be up at the footy oval doing agility. It's very, very dynamic, and it does require a lot more energy than just the effort that you put into them in the 30 minutes within the consult and writing their notes. It takes a lot more attention because you're ultimately, even when they're well, wanting to see them succeed, win that flag, whatever it is. And for me, the performance goal isn't just the athlete. So sports osteopathy for me can then migrate into the fact that I believe everybody deserves a performance goal. There is a return to retraining and return to play protocol for concussion. There's a whole lot of treatment approaches. There's a whole lot of considerations for lifestyle, for returning to school, but there's a pacing program. There's a traffic light system for going up and down, progression, regression, for concussion, for knee injuries, for post-surgical, for everything. So what I typically would do in a consult then, so what does the consult look like for me the first time I meet someone? I gather as much information about the person or the athlete or the performance goal that I need. I like to then have, that I've learned off all of the, whether it's surgeons or, the elite physios in hip or shoulder care, that screen, that really great orthopedic, osteopathic static, great orthopedic examination, I then will always put in a performance parameter of test of performance pay. So it might be gathering that more subjective or objective data. So for me, if someone comes in with an Achilles pain and they've been seeing physios and whatever, and you go, okay, I'm going to look at the Achilles, I'm going to treat the calf, and it sounds like it's a bit weak, so I'm going to give you calf raises. I can't understand why anyone would ever give anyone some strengthening. If that's been around for 2 years, why haven't you done a calf raise endurance test? It takes literally 2 minutes to see whether the left and right from a limb symmetry index, whether they're doing the same thing. So subjectively, objectively, I will get more performance data from calf raise tests, single leg rise, single leg bridge testing, single leg rise testing, trunk endurance tests. What is the capacity of that tissue when it's at its best? And have a look at it when it starts to fatigue. Because if you're not trying to find that data, it's like driving a car with a flat tire. It might be okay to drive it around town, but as soon as we try to demand any performance of this athlete, we're going to find that flat tire is going to cause issues somewhere else. And heaven forbid how many times I've had someone give calf raise program to someone with a sore Achilles, but their left side was fatiguing at 11 when they were so hyper focused on fixing that Achilles for 2 years that it actually had become the strong one and the one that they were using more than actually balancing the limb symmetry index. So I can get a lot of information in 2 or 3 minutes after the osteopathic screen and scan to then actually go, I've got so much data now. Doesn't matter. I can treat like an osteopath, but I can already see the last 15 minutes of this consult because I'm going to grab some things, 1 or 2, performance goals that we're going to try to see if we can fix for a start. So again, understanding that I have a responsibility. I love fixing people. I love treating people and finding the balance. But I understand that their actions, habits, attitudes, behaviours, and environments are going to swing that pretty quickly if we don't find some changes to those parameters. So that's how I treat like an osteopath. And it's pretty full on, but I've gotten really good at it and doing it quickly over the years.
Has your osteopathic mindset, or has the rationale that you use within your own thought process, has that helped you develop the rehabilitative side? Like, have you just taken the rehabilitation that you've learned from a lot of the doctors and orthopedic surgeons and the sports physicians and the physiotherapists that you have looked at and said these people are doing some great things? Have you just kind of incorporated all that and kind of used that? Or have you put that through your own filter and
absolutely,
and put your own kind of osteopathic mind to that? And tell us, has there ever been a time where you looked at something and said, this doesn't make sense? Why are they doing it that way? Can you give us an example of that? Can you give us an example of someone doing something and it just didn't make sense to you and how you were able to adapt it using an osteopathic approach?
Yeah, I think you asked a lot there. For the first part of it, I think I've had the best world of being able to adapt everything that I do because you've seen everything else. Because I've sat with chiros, with physios, with sports doctors, with surgeons, you're able to sit in there and go, I already knew that. Because we didn't learn sport at university. We didn't learn this. We didn't learn a lot of rehab. We did a little bit, but not a lot. So everything that I've had to learn, I've had to learn outside of osteopathy. And, in terms of professional development, I would have spent close to $250,000 in 15 years on business excellence, leadership, osteopathic CPD, sports medicine CPD, all of my online subscriptions, Learn Physio Network, all of the research data that comes in, because I have to, if I'm going to sit on the board for SMA in the vice chair, I've got to understand evidence-based physio approaches. I've got to understand all of that. But it's really nice to go down and sit with them and go, you've got the osteopathic philosophies and you can understand how the hip relates to the knee, and you can see them narrowing in with their focus, but going, that's a great exercise and that's a great exercise. But I reckon if I combined that with a bit of a knee approach and tweak that exercise a bit, we're going to get a better effect on the whole limb. And, doing like all of those FMS, Greg, like all of those different ways in which you can assess the body, and, then formulating, the rehab off the back of that. And yeah, of course, there's always times I like to think of, I think if you've got lots of different approaches and you're trying to treat something osteopathically, you understand pretty quickly whether or not it just needs to be a hands-on approach, or whether or not there needs to be a rehabilitative component. I think, because you've done the measurements, you've done the testing, gone, actually, you're pretty strong. I've done all your strength measuring, I've done your reflexes. Actually, your motor capacity is really good. Your sensory is intact. You don't have any pain inhibition and things like that. So you're actually performing well. So actually, yeah, we could just treat you and make you feel good, and hopefully your body's right. But if you use all those parameters and realize that there is a deficit there, the testing for me just becomes the rehab a lot of the time. With your advanced testing, your orthopedic, your range of motion assessments, and those different types of tests, once you know them and you can whip through them, then you can do your physical testing. The physical testing or functional testing then also becomes your first entry point. At what point did they fail? Can I go back and start at that entry point and say, hey, this is actually your rehab. Let's see if we can achieve this in 2 weeks' time. So, and then when you go back to specific examples of a time when nothing made sense, it's amazing that, I suppose, because you understand a little bit more from lots of different approaches, when you don't understand something, it hits you really quickly. When a young boy's coming in or something like that, and he's got shin pain, which most people would diagnose as medial tibial stress syndrome, but you pick up the things about, the pathology that we learn about sleeping and the nighttime and lymphadenopathy, and all of a sudden we're getting, shin x-rays, for leukemia and looking for sarcoma and those sorts of things. When a young boy is not just fatigued from playing basketball and needs to just stop playing sport for a little while. So, and there's always those times when things hit you and you can't really put it together. When, someone's come to you from the physio diagnosed as bursitis, but you've put them through the screen, they've got all the testing, they can throw, their functional capacity is great. And you're like, this is not bursitis. There's something actually going on in the breast. Or, once you've looked at lymphatics, you've looked at their pulses and all of those sorts of things. Why are they getting this numbness in their arm or whatever? Okay, it's not the neck, it's not the shoulder. They passed all of my performance tests because, often as well, subjective and objective is always just what you're picking up from an assessment with them in front of you. I can do that through telehealth very, very well as well. So as a sports osteopath, I could do it to you right now. Again, there is rate of perceived exertion, so what they're telling you, how tired they are. But then if you count, you're also getting the number. So if I do a calf raise test on you, I can say how, you might get to 30 both sides, but then I say, but how hard was it? And you might say, oh, my Achilles side was actually easier than my better. It was a 7 out of 10 on my Achilles rupture side, but it was a 5. I found it really hard. I had to really strain to get to 30 on my good side. So you've got, the rate of perceived exertion by the patient. You've got the numerical value of what they actually got to. But then if you really want to rip them apart, you can put them on the force platforms. So that's when you can use technology. We've got the strength by numbers. Shout out to Andrew Lemon and the crew. Whack them on the axis, give them a groin squeeze, give them their, the knee extension, knee flexion tests. Have a look at their, jumping, hopping, landing, their weight distribution, because that stuff's going to give you some real data, and then whack them on the floor with the push it and, get them to do an athletic shoulder test so that, you record the force that they're pushing through that shoulder. So I've had this person come, it smells and sounds like subacromial bursitis. It's keeping them awake at night. They can't lay on that shoulder. But then you do all of these tests and you realize that, hey, hang on, there's actually something happening in this chest wall. This is completely different. This shoulder is completely, they've maxed the tests on both sides. So for me, that performance review just gives me more information where I go, hang on, this doesn't make sense. I'm not sending this to a sports doctor. This is going to a GP, those sorts of, as an example.
Right. So, okay, well, let me ask you then the next question about maybe sports specificity, I guess, or whatever you want to, we'll get to that. But most athletes, if they come and see you, it's generally because if they've had an injury in performance, right? they've done something to their shoulder or their hamstring or their knee, and it's generally either during training or during during some kind of athletic performance. That athletic performance is quite a specific skill set, and it requires that they've trained many years to get there.
Yep.
When you run them through your tests, that from what I understand, a lot of these tests, as functional as they are, as what we call functional, they're not. I don't find them being very close to reproducing what actually happens out on the field,
Of course.
or up on the mountain, or wherever you want to apply that sport. And so, how do you reconcile the tests that you're doing with the fact that you might use the tests to then develop your program, to develop your rehab strategy or plan, and then they go back to playing their sport, and the holism of the actual sport hasn't been addressed. How do you address that?
Well, that's where that's sports osteopathy. It's actually understanding athletes. So not just going to do a shoulder course, go to do a shoulder course for throwing athletes. Yeah. So, for those listening, everyone always says, well, where do I learn this sort of stuff? And, I've been online, and you've got your subscription services, but, some of the other ones that people might know in regards to just general SMA conferences, there's lots of stuff happening all the time. But, another one with Nick Kane in the Sports Map symposiums that they have. They've been for the last 4 or 5 years running very, very specific to the specific athlete, whether it's for AFL, the athletic groin pain symposiums, the rehab my calf. Then there's been the sprint speed ones, working with Renelle Hobson in the Australian Sprint Speed Academy, going to watch her do ankling biomechanics of running and how you coach running technique, all the way down from, different starting positions and sprint speed and, the drills required to develop athletic power, working with the strength and conditioning coaches and going to the gyms and watching how they rehabilitate it. But yeah, again, going to, that sports one on an upper limb shoulder rehabilitation for throwing athletes, making sure that the CPD is really specific so that when they come into your office, this is the reason why you can't just have, if you're interested in these things, you can't just be working in a clinic that only has 3 treatment rooms. It has to have a gym. It has to have space. We have a big driveway. We sprint up and down the driveway. We watch them do the agility. We've got a treadmill. We've got a bike. So if they're a cyclist, we watch their cycle performance. If they're a runner, we watch their running performance. If it's any sort of limb, if it's a hip bursitis, a knee injury, an ankle injury, we're looking at limb symmetry index on a box and doing all the static stuff, but watching the functional dynamic. But then after 3 sessions, we're also down at the football field and we're watching them as well. So
Right.
You've really, for me to write an ACL program, it could be something different each week. It's basically what we call throwing the kitchen sink. So there isn't a cookie. Everyone always say, can I have your rehab for ACL? There is no cookie cutter model. It is athlete specific. It is tissue specific. It is injury phase specific. And it's also has to be regressed and progressed as the athlete. So you have to be collecting the performance data. You have to be doing the athlete wellness and those things.
Right. So sorry to cut you off, but that data that you just described there, in terms of watching the athletes sprint, watching them in the field, performing the sport, is that ultimately giving you better data than, say, doing your calf testing? Specific calf testing.
Yeah, of course. And it depends on how depth you want to go, because you're using things like, if you've got a runner, you're using running performance parameters. You might be like, is your 5K time trial time improving? What's your pace doing? You're looking at running data. So you're getting them, you're getting to their Strava data and their Garmin data. So you're using different technology. If we're working on sprint speed, we've got the timing gates. If we're working on vertical jump, we've got a vertical jump tester. We want to give a rehabilitation, but we need to measure whether or not that's been effective. So we pre-test and we po-test. And again, I do a lot of this generally with my day-to-day general population for knee and hip osteoarthritis. Everybody likes to see some data. And I think one of the best things is when you get them in day one, you say, hey, there's a lot going on here. This is going to be potentially a long road. But what's really important to me today is to show you and expose to you the things that you can't do. And they do some funny things in front of a test. And never have you ever put a person on a chair in front of a mirror and told them to do a single leg sit to stand test to let them see. Have you ever put them on one foot and done the eyes closed, in the 9 seconds eyes closed test, and watch how a 45-year-old woman can't stand on one foot for 9 seconds with their eyes closed and wonders why they're getting hip bursitis? But again, standing on one leg, the sit to stand, they are all skills to be learnt. Kids are really neuroplastic. They learn skills really quickly and they retain it. And as adults, we might be 40, 50, and we're trying to do skills that we think we remember how to do. But when you actually get them to do it and you pull them apart in front of a mirror, all of a sudden we realize that they haven't been able to retain that neuromuscular patterning or control. So, I always say there's two types of strength. One, how big is my TV? And then two, the neuromuscular control, how good is the signal? So adults, all types of people, they need that dial in of neuromuscular control and strength. And that can be as simple as teaching them one skill. You teach a person in their 50s to stand on one foot. You can then get them into a functional test and in achieving that easier because their brain has got this attrition now for learning some skills, even though they're a bit older, and their performance usually improves as well. So you show them what they can't do. You say, we're going to go through this phase of treatment in the gym. We'll come back to treatment. Here we'll do a retest. And you can give them that 12-week approach and you can get a really good buy-in because as soon as you get them on the force platforms and you get a bit of data, as soon as you start retesting them, they go, holy crap, I am getting better. Because pain is relative, can be relative sometimes. Headaches, we know that they can get be getting better or getting worse, but they might think they're getting worse, but the reality is they're just not taking any Panadol anymore. So pain and what we're doing is relative and performance is relative as well to improvement. So it's just another way to get really good buy-in.
So moving on from a lot of the things we've been discussing with regards to, I guess, what you're doing in practice, tell us about your mentoring. Where are you going with what you're doing now with mentoring? What's your aim for that?
Look, I've, as I said, my life's been this massive cross collaboration of so many things. My life as well. I'm not motivated by money. If most people have been following through my life, might find it hard to believe that I've never done anything that I've ever done for money outside of the treatment room. So, even Sports Network, I dedicate, 2 weeks of my life to working with the Air Force, that I run student clinics. I get supervised in about 7 or 8 osteopathic students to come on Air Force Base and run those clinics with Baseball Victoria. We did some Rookie Me, Shani Layton, Hockey Victoria. There's been so many girls' footy programs and all of this stuff that I've been able to either be a teacher in the sporting world or of students. So putting my hand up, I've been, working with Victoria University and RMIT for many years now as a transition or induction advocate for rural practice and sport. So I think I've been at VU and RMIT most years. I've, worked with SMA for so long that I've become a sports trainer accreditor so that I, when I started Osteo Sports Network in 2018, I was running all the sports trainer courses. And, I think in 2018, I trained 120 student trainers from RMIT and VU just so that I could give them jobs in sporting clubs. So, there's been a lot happening with the mentoring and, as other people know, for the last 10 years, or 8 years consistently, I've been driving to and from Melbourne each week. So I'm mentored while I drive, Growth RX Jade Scott, with Clinic Mastery, with a lot of the people that I've, been affiliated with, surgeons and sports doctors, the mentors that I had for my case studies for my sports application. But then in that car, I'll also turn that into mentoring as well. So for people that want to be a sports osteopath, they're having some trouble in rural practice and business, they want to know how to recruit to rural practice. And again, I'm so grateful that I've got such great mentors in my life because, as someone said, is that, nothing that I speak is my own. My energy and my frequency and my values are mine. But the things that I teach, I'm recycling. As I said, I've spent a lot of my life in professional development, $250,000. It's not a new message, but I'm just a new messenger a lot of the time.
Yeah, no, there's nothing new under the sun, right?
No, that's exactly right. So I'm really, really fortunate to mentor a lot of the guys that come through Osteo Sports Network, that come through the events that we run. I'll chat to a lot of the fifth years in regards to just who are good bosses and, what do they think? And I'm having trouble with my boss. And I go, have you thought about doing this? Because this is what I do with my guys. And I think a lot of the early career graduates have sort of followed what I've done with Osteo Sports Network, but our outreach osteopathy across 40,000 square kilometres of Mallee and, the student fostership and internships that we've done is that you end up becoming this little point of call. So I get a lot of calls, and I've spent a lot of my life in my car doing everything for everybody and giving them information for nothing. So I
Give
pride
give
myself
us
on that.
give us the case for rural practice, like, make it, because the people are listening, and
Yep.
and it's hard these days to get people to come out. I mean, to areas that are outside of where the universities are located. Um,
Yep.
give us a brief case for why people would enjoy rural practice.
Hello, everyone. Just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So, the two best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes. So, for more information, please see the show notes. Now, enjoy, and back to the show.
Well, I mean, I can't speak for everybody else's clinic, but our clinic, one, you've heard my story to Sports Osteopathy. So one, not to be afraid that you can't be, what you can't see just because you want to try rural practice. I believe that everybody should try it. I think this world is so overwhelmed right now by social media and all the things you have to do in life, rather than just being content, the understanding that, we inherently change all the time, and that it's okay to sit somewhere for 2 to 3 years and actually really, really invest in what you spent 5 years learning, CPD and having a good mentor and whatnot. So I'm proof in the pudding that just because you work in rural practice, that you can't run a national sports network, sit on the SMA boards, go into the universities. It's just your drive and how hard you want to work and drive towards, all those types of achievements. So, in rural practice, it's also, in 2020, we were so lucky to be able to do essential service. So we expanded our clinic from Central Mallee Health in Swan Hill, Sea Lake, Kerrang and Birchip. Our home base is Swan Hill. It's 45 minutes to an hour out. We all go and do one of those days at our main clinics each week, just so that we can work the capacity. But my clinic now believe in the same mission that, no Mallee person deserves to go without access to healthcare or allied healthcare. Anybody that we recruit believes in that mission. And the beautiful thing about my team and why I love them so much, and, I implore you to all sort of recognize the work that my team are doing, because for nothing other than the fact of the pure joy that it brings them to have a day out of the normal clinic day-to-day confines of the treatment room with a fresh approach to just getting out of that rut, to get in the car at 7 o'clock, drive an hour and a half to Robinvale and have 15 clients. Doesn't have to be pretty to be perfect, but they see 13 to 15 clients. They get sore bleeding up to their arms. Yes, it's messy. Yes, it's hard. Yes, it's tough. But you come back from those outreach tours where there is no GP in that town. They have very limited access to emergency service, teachers, nurses, everything. And instead of going out to those places, with this imposter syndrome, or like being in the city where it sometimes can be a bit of a paid for service, there's an expectation. Hey, I want a haircut. Here's the money. Here, I want my neck cracked. Here's the money. They've had access to it their whole lives. They've been to physios, chiros. They know the works. They know the who's who in the zoo. But when you drive out to Patchewallick and you work in the community hall and you've got a woman or 4 women for the day that sit in front of you with tears in their eyes going, I can't believe I've never heard any of this information before. Thank you so much for coming. Please, can you please come back? Thank you for seeing our small town. Thank you for paying that $100 to our small community facility. It's not until you experience or feel that deep gratitude that comes back at you that you actually understand and remember why it is you studied what you studied, why you do what you do, and why you will continue to do it. So it's, I feel that a lot of that can be really null and void. Not to mention, again, the massive wide demographic, the crap that rolls through the door. It's not just the neck pain. They've got gout, they've got a dislocating wrist, and, and they've got this skin cancer on their back they didn't know about. And they've had 7 injections in their right shoulder and a really crappy knee replacement on the right. And you just look at this person, you've got 45 minutes in this small town and just go, I'm not sure when I'm coming back, but I want to do one thing that's going to be the most helpful thing for you today. And that might be referral networks. It might be giving them hands-on. It might be just listening to them. It might be whatever it is. But you get a patient for life that way. And that's when you get that profile or reputation growing, where people will drive 2 hours to see a young girl in Berrywillick because she applied that level of care. You do not experience, and I've worked in the city and I've mentored a lot of people, and for me, We cover 40,000 square kilometres of the Mallee. It's a big place. It's 4 hours from point to point. There's about 30 locations that we do, and my team affectionately commit to one outreach effort a month, and we piggyback our interns, our teammates on that. So what a great day to jump in the car with your colleague that you normally like ships in the night and have a really meaningful and memorable day with them. And at the moment, if people are listening, if you jump on Outreach Osteopathy, anybody can come up. We've had advanced practitioners come up to the clinic before, most notable in Marnie Norfolk and Dina, who came up to do some advanced paediatrics. So all of those difficult cases and saying, hey, look, we're going to put them all in. They're going to come up for 3 days. They drive up to Swan Hill. We go and do a day in Robinvale. They stay at the local my home farm. They see the tractors and the cows and the sunrises, do a day in Birchup and keep going home. And they always get back to the city just going, wow, that was great. It was hard work, but geez, that was great. And since then, we've been able to do, we've recruited a solution psychology. We're in talks with an allied health company. We're looking at doing some outreach sports doctor. So for anyone interested, if people just need, if they've got particularly working in transitions with other business owners. So Sammy, if you've got a job, for example, in Melbourne and you don't, you can't really afford to contract because your clinic's not quite busy, but you haven't got full time, why would you let that beautiful student go and find another job to be mentored? It's like having two boyfriends at one time. But Sammy, could you give them 3 days? Give them 3 days of part-time work. Give them to me for outreach for 2 days for 6 months. They'll come up, accelerate. They'll be treating 30 clients in those 2 days. Accelerate that change in their confidence and the removal of that imposter syndrome. And then they come back to the city and they transition after 6 months. They've helped the outreach program because they looked after a few towns, and then they come back into a more, a better clinical caseload in the city over time. So that's what we're doing. We've got a transient approach. We've got our key local staff, and we've got a transient approach to the 12-month or 6-month practitioner. So we have an intern at the moment who's been interning in his 3rd year at VU. He's now into his 4th year. He'll be graduating. He'll do a 6-month contract with us, but we'll have an intern piggyback our outreach for 6 months. They then handle the outreach with our youngest practitioners, and then it's like this little changeover. So we're really super excited about the way we can foster those experiences in rural practice and give people that confidence they need. If anyone wants to join that, Sammy, if you want to come for a drive, we always say, look, come up on a Monday night, run our team time on Tuesday. We'd love to have a guest. And then, you might find that on the Wednesday you go through an outreach experience. You might go over to Hopetoun and sleep in the Mallee Bush Retreat in the silos, where we sleep in these $30 rooms up in these big grain silos on stilts, and then we flip them into 6 treatment rooms in the day. You treat all day, drive back to Melbourne via the Silo Art Trail or Lake Tyrrell, the Sky Mirror. It's this holiday, but it's meaningful. And anybody can be a part of it. So our outreachosteo.com has all of our student stories, which we've been developing over about 6 years, and our schedules on there. So, my probably advice is have a crack, have a try. And if you don't know, just come and try some outreach. Come and get in the car and physically see how it makes you feel.
It seems like your entire kind of setup is a mentoring, you could go out there and just... the experience itself is like changing for you as a practitioner.
Yeah.
And so
but
it's not
really,
just... Yeah.
It's a really great business model.
Yeah, from what I understand from what you're telling me, this is the first time I've had this conversation, it's not just about getting your hands on people, although that's a part of it. It's the actual practitioner experience that changes you as a practitioner. That's amazing. I think it's fantastic.
From a business point of view, like we understand that there's these performance capacities to the people that work for us, but they're also these emotional human beings who inherently need to learn what empathy is and what compassion is and how it makes them feel. And so, there's
what a place to get it.
There's a massive personal investment in our people, which is probably the biggest thing. Until you understand, until you can get them to take their shoes off and understand who they are, they're never going to perform as a great practitioner until they can learn who they are and how they respond in the industry. So for me, it's a great business model to support the students, not just through Osteo Sports Network as sports trainers, through Baseball Victoria and our placements. I implore anyone, if you want to be involved, any osteopath can come and join us on base in this March, to help supervise. giving some of your time to pass on something else outside of, the university structure. They're sports trainers, so they're covered. And we have this little loop where we provide those pre-game, post-game, injury management clinics. Well, I think we put maybe 14 or 15 students through last year, and we probably had 6 supervisors. So it's an amazing opportunity. It's just about getting involved. For me, it's a great little network then around, well, Sammy, if you come and help me with the Osteo Sports Network, you get to meet these students in the flesh. You get to see them in that sport world, and then you might foster those internships or those relationships, or that you might be their future employer. They get to see lots of different osteopaths working in real time, and whether or not they want to be like them or be mentored by them. And, I think it's a great connection piece, for rural practice for us and also for sport. So my biggest advice is, one, if they're at university and they're not increasing their involvement for me is huge. If they have only studied, if they haven't worked as a sports trainer, been involved in events, touched people, in any capacity, and gone and met clinics like yourself and had a treatment by you and explored lots of different modalities, I look for involvement. But then, that's a big tick for me. But then as well as that, be willing to just try a few different experiences to understand where you want to be.
I'd encourage everyone to reach out to Louise and find out how to do that. Louise, it's been a very enjoyable kind of time I've just spent with you, and we really haven't had a chat. This is the first time we've got to talk, so it's been amazing just to hear what you're doing out there, especially in the rural, in regional areas, and kind of I've had experience growing up on farms as well. My father, when we emigrated to this country, worked on a farm to kind of start making some money, and we spent a lot of time out there. They're just the people that live on farms, and the farmers, and the way they behave, and just the problems that they have, and how you can do so little and make so much change. It's amazing. So I encourage people to get in contact with Louise if you want to go and do that. The final question I want to ask you, Louise, you've got a magic wand, and you get to influence, I guess, where osteopathy heads in the next 20 years. What would you like to do with it?
I think inherently, as it is, much the same. I like the way in which osteopathy is taught. If I had a magic wand, I'd just remove TikTok and Instagram, fire cupping, needling, anything that's not, all the circus tricks. I think there's a lot of that. There's so much social pressure on, these career graduates that are coming out, starting their own clinics. I have no problem with it. But the problem with the way in which they apply things, if I see fire cupping, needles, and ball rolling on the bottom of the foot and some glute stretches, go find a good mentor, do some good CPD.
Right.
I think the investment in 20 years' time, I want to see people still face to face, connecting with inherently the human body. You have to connect with bodies a lot of the time to learn. I think the preservation, I had a really, really great opportunity to go to Fit for Practice recently, which is an incredible seminar, with Bruce Duncan, Michael Salerno, Tim Taylor, all of those, sorry if I didn't mention them, but amazing osteopaths. And you inherently learn osteopathy from spending time with people face to face, touching bodies, and preserving that knowledge that they're passing down. They're the messengers of the, not a new message, but they're the messengers. So it's important to sit in front of them. And I'd implore, yes, it is tough in today's society, the cost of living. Just went to South Africa with a 60% decrease in the cost of living in Cape Town. I was like, I want to move there. It's really hard to live in Australia. It's really hard as a graduate to earn money. But they are the future. In 20 years' time, this is what's happening. So what I'd like to see in 20 years' time is the preservation of those principles, the art of osteopathy still filtering down in that face-to-face, and, less social media pressure and to try to create followers and this with these crappy techniques, and more of an investment for students in their first 5 years to invest every dollar they spend in themselves in learning osteopathy will never be a dollar wasted, and it really will help them understand their future career pathway, because their career pathways are essentially influencing our industry in the future. So less social media, more face-to-face.
Yeah. Louise, I want to thank you for joining me tonight. Hang on the line with me for a couple more minutes, but for everyone else, a big thanks to Louise Bibby. Keep doing the great work you're doing, and I'll catch you on the next episode. Thanks, Louise.
Thanks, Sammy. Great work.